Morning, everyone. We're going to start this morning with the talk on pharmacology. I think it follows a little bit better from our discussion about the pathophysiology of type 2 diabetes that we had on Friday. So we're going to spend the first hour talking about pharmacologic therapy for type 2 diabetes, and then we're going to take a short break and begin our discussion about diabetic complications. We'll do most of that today, but we'll finish up with our last lecture on complications tomorrow morning with Dr. Orezzo, who's going to talk about neuropathy. And then, as I mentioned earlier, we have a patient of mine who has type 1 diabetes who's going to come in and speak with you at 9 o'clock tomorrow morning. Okay, so let's jump into pharmacology. And as I said, I think this is a good kind of follow-up to what we were talking about on Friday. You know, we're going to talk a lot in the next hour about individual drugs and therapies for type 2 diabetes, but I think the most important thing that I'd like you to take away from this is not necessarily the details of specific drugs and their doses, et cetera, but more to think about the drugs that we have available in terms of how they affect or interfere with pathology or pathophysiology of type 2 diabetes, how they address specific molecular defects that lead to hyperglycemia. And so this is just kind of a good overview showing you the main players that we talked about last week in terms of the production of hyperglycemia in type 2 diabetes. There's increased hepatic glucose production that contributes substantially to hyperglycemia, especially in the fasting state. We have impaired insulin secretion in type 2 diabetes, and in most cases there's some insulin resistance or impaired insulin-mediated glucose uptake in tissues such as skeletal muscle. And so all of these defects could be targets for drug treatment, and interestingly, we do have drugs that target them in different ways. I put another organ up here also, actually apropos of your neurology course. And that is we're beginning to understand more and more that the brain plays a very important role in regulation of glucose metabolism. And actually some of the drugs that we have currently available also do target central mechanisms. So we'll mention that in passing. So as we're going through the drugs, kind of think back to that scheme and the different defects that we're kind of targeting with our different therapies. So here's a list of the drugs that we're going to be discussing today. The biguanides, insulin secretagogues, or drugs that stimulate insulin secretion, drugs that help to improve insulin sensitivity. And then there's some drugs that work by different mechanisms. The alpha-glucosidase inhibitors slow down intestinal absorption of carbohydrate. And the newest class of drugs here is the SGLT2 inhibitors, which actually promote the loss of glucose through the urine. And then finally, we'll spend a little bit of time talking about insulin therapy, specifically in the context of type 2 diabetes therapy, because I think Dr. Shimoon probably did mention a little bit about insulin in the type 1 lecture. Now, there's three other drugs I put over here for completeness sake. They're all kind of interesting, but they're not drugs that are very commonly used. Their effectiveness is relatively mild, and they have side effect profiles that tend to make them less desirable, but I'll just mention them so you'll know. Colesevelam is a bile acid binding resin that's also used to treat hyperlipidemia, but it has an effect to lower glucose and is approved for that use. Its mechanism of action, specifically in lowering glucose, isn't really clear, but it may be through stimulating the secretion of an incretin hormone called GLP-1, and we'll get back to that later. Pramlintide is an analog of amylin, which is a peptide that's co-secreted along with insulin, and it seems to have some effects to kind of boost the effectiveness of insulin, and is used primarily in type 1 diabetes, although it's available for type 2 as well. And bromocriptine, which is a dopamine agonist that's used in treating Parkinson's disease and also in hyperprolactinemia, seems to have, or does have, some glucose-lowering effect through mechanisms involving the central nervous system, obviously. But as I mentioned, the efficacy, the potency of these drugs is really pretty small. So that's all I'm going to say about those drugs, that you just should be aware that they are approved for diabetes therapy. So we're going to start with metformin. And metformin is one of the oldest drugs that's been used to treat type 2 diabetes. It's been used around the world since the 1950s, although it wasn't approved in the United States until the mid-1990s. It's generally accepted to be the first-line therapy for most patients with type 2 diabetes unless there's a specific contraindication. And after we've talked about it a little bit, you'll hopefully get a sense about why that's the case. It really has a lot of very favorable properties. So the mechanism of action for metformin is through reduction of hepatic glucose production. Very important. Remember, that's a major contributor to fasting hyperglycemia, and that's where metformin works, primarily through inhibiting gluconeogenesis. It also, somewhat probably secondarily, has an effect to enhance insulin sensitivity. That's been a little controversial, but it seems that we do observe that clinically. And the effects, the sort of cellular effects or molecular effects of metformin seem to be mediated by activation of this very important intracellular signal called AMP kinase, which acts as sort of an energy sensor within the cell, and it really is a key target for some other therapies for diabetes as well. One of the other things that metformin does is reduces the production of free fatty acids, so free fatty acid levels are lower, and that may be one of the reasons why insulin sensitivity is a little bit improved with metformin. And some of the early data with metformin suggested that it may actually decrease intestinal glucose absorption. So people eat, but all of the glucose doesn't get absorbed. We're not really sure how significant this effect is, but it does have an anorectic effect, and the result of perhaps decreased intestinal glucose absorption, and certainly the anorectic effect, is that it's very common for people when they initiate therapy with metformin to lose a modest amount of weight. And as we talked about before, since obesity is a major factor in type 2 diabetes, any amount of weight loss is clearly beneficial. So I'm showing you here just a typical profile. We're going to see similar slides for some of the other drugs that we're going to be discussing. And it shows you the daily glucose profile. Here in orange is the pre-treatment. So here's the fasting blood sugar. Glucose goes up in response to the first meal of the day. It comes back down. It goes back up again in response to the second meal. And you can see with metformin that it definitely reduces fasting glucose levels. Doesn't do a whole lot to prevent the post-meal rise in glucose in this case, certainly in the first meal of the day. And I just show that to you for you to again get the picture that the predominant effect of metformin is to lower fasting glucose levels, with secondary effect perhaps on postprandial blood sugar levels. So in terms of efficacy, metformin is probably one of the more potent of the anti-hyperglycemic drugs that we have, with similar degree of glycemic control as sulfonylureas, which is the group we're going to be talking about next, but they don't stimulate insulin secretion. So as I mentioned, there's no weight gain, and in fact there's modest weight loss in many cases with metformin. And because metformin does not interfere with the normal regulation of insulin secretion, there is really little or no potential for hypoglycemia, and that turns out to be a major benefit when we're talking about diabetes drugs. The most common side effect with metformin, and it's actually very common, is gastrointestinal. People typically will have some mild nausea, dyspepsia, diarrhea, especially when they begin treatment with the drug. Most of the time, by slow titration and sort of a gradual initiation of treatment, people are able to overcome this and tolerate it long term. But there are some people who just cannot tolerate it. And one of the other side effects to be aware of is that especially long-term treatment with metformin can lead to vitamin B12 malabsorption, which could result in B12 deficiency anemia and also neurological problems. So monitoring of B12 levels is recommended. The most serious potential problem, though, with metformin, I mean, basically everything that you're going to hear about metformin is great. It's very favorable, with one exception, and this is the possibility of a rare but very serious adverse effect, which is lactic acidosis. And this is actually a big a concern when metformin was originally approved. That's one of the reasons why it took so long for it to become approved in the United States. There was an earlier biguanide called fenformin, which had much higher rates of lactic acidosis, and that was removed from the market. And so there was a lot of concern when metformin first came available that we would see that as well. And it turns out that it's actually much less common than we had expected, which is a really good thing. But it is something that has very high mortality rate, and so we really want to avoid it. When lactic acidosis occurs in the setting of metformin therapy, it almost exclusively occurs in patients who have clear contraindications, which I'll tell you in a minute, and generally in the setting of some other acute illness, sepsis, shock, something else that also would tend to trigger or promote the development of lactic acidosis. So as a de novo occurrence in an otherwise healthy person, we don't see lactic acidosis. So the contraindications that you should be aware of for metformin treatment is severe congestive heart failure. And now the packaging material will say anyone with congestive heart failure who requires pharmacologic therapy. That's, I think, probably more strict than most physicians apply the rules. But certainly someone who has decompensated or severe congestive heart failure because they may tend to accumulate lactate on the basis of hypoperfusion should not use metformin. Binge alcohol use is a contraindication because that also can predispose to lactic acidosis. Someone who has a chronic metabolic acidosis for some reason. People with severe liver disease. But the biggest one, the most important contraindication is renal dysfunction. And recently, I put this table up for you to see, but recently the prescribing recommendations for metformin have been relaxed considerably. So based on the estimated GFR, you can see what kind of monitoring you need to do in order to be able to use metformin safely. Certainly, if someone has an eGFR greater than 60, that is no problem. In intermediate ranges between 45 and 60, that there should be increased frequency of renal function monitoring. And then when the eGFR gets down to the 45 or 30 range, you really have to start considering discontinuing metformin and trying another drug. Now, one of the reasons why we like metformin so much, okay, so there's no weight gain, there's no potential for hypoglycemia, the side effect profile, as I mentioned, is really pretty minimal with the exception of lactic acidosis. And there have been other reasons why this is really turned out to be a preferred drug. And that one of them has to do with its potential for cardiovascular benefit. And so you can see here a list of different studies that have been done that showed favorable effects of metformin on lipid levels, on oxidative stress, on different measures of vascular function or coagulation. But I think the really important finding here was from a major study, which we'll talk a little bit more about later, called the UK Prospective Diabetes Study, which showed that treatment with metformin compared to conventional therapy, which did not include metformin, reduced the incidence of myocardial infarction by 39% and all-cause mortality by 36%. And you can see here two slides from that study showing here any diabetes-related endpoint. Metformin clearly preferred over the other therapies, and diabetes-related death was also reduced. So there's pretty good evidence that, that metformin, perhaps independent of its effect on glucose control, seems to have cardiovascular benefits. And I'll just mention one other thing that's kind of a hot topic in the field of diabetes right now, and that's the possibility that metformin may have some benefits in terms of preventing cancer. Now, this is not something that's been proven conclusively in randomized trials. I think there are a number of studies that are ongoing now that may address it. But a number of observational studies, and here in this case I'm showing you a systematic review and meta-analysis of a number of kind of observational cohort studies that has suggested that the relative risk of developing cancer is lower in people who are taking metformin. And there are a number of mechanisms that have been proposed, and some of them are related to the actual AMP kinase, which is involved also in mTOR signaling. It's the known molecular mechanisms of metformin are potentially involved in a tumor suppressive effect. Directly. And then also we know that by lowering insulin levels, there's a tendency to reduce cancers by reducing the mitogenic effect of insulin. So whether this observation will actually turn out to be confirmed in randomized trials, we don't know, but it is something to keep in mind. You may be hearing more about it in the next few years. Okay, any questions on metformin before we move ahead? Okay. So the next class of drugs, I'm sort of going in historical context a little bit, are the sulfonylureas. And this is also been available for a very long time. Really, these were probably the second class of drugs after insulin that became available way back in the 1940s and 50s. And these are drugs that stimulate insulin secretion. So you can see here there's some older drugs, the first generation sulfonylureas, which are rarely used in the United States. But if you're involved in global health, you're traveling to Africa or some other place, you may actually find people still being treated with these older sulfonylureas. Glyburide, glipizide, and glimepiride are the ones that are commonly used in the United States. And one thing to know here is that they have a fairly long duration of action. So most of the time they're taken once a day or occasionally twice a day. But remember this when we talk about what the major side effect is of sulfonylureas, because that becomes important. So how do sulfonylureas work? Well, so here's a cartoon of a typical beta cell. And you can see insulin is in these preformed secretory granules. And so how is it that sulfonylureas help the insulin get out of the beta cell into the circulation? One thing I'll mention before we jump into that is, of course, if you don't have beta cells, right, this is not going to work. So people who have type 1 diabetes, for example, do you think sulfonylureas could help them? No, because they don't have any beta cells, or very, very few, that could respond to a secretagogue. So these are drugs that are only used in people who have type 2 diabetes. Yes?
Can it extend the honeymoon period in type 1 diabetes?
Well, that's a good question. I don't know that it's been studied in particular in that setting. And one of the reasons maybe why not is, we'll get to in a minute, but there's been a notion, I don't think it's been well substantiated, but there's been certainly a school of thought that drugs like sulfonylureas that stimulate insulin secretion may actually lead to exhaustion of the beta cells. Right? So it may actually cause them to fail earlier than they would have otherwise. I'm not saying that that's really known for a fact, but it's kind of a conventional wisdom thing. So the typical regulator for insulin secretion, as you know, is glucose, right? So the body is very tightly tuned so that glucose availability starts to increase. There's increased glucose uptake into the beta cell, which leads to glycolysis and metabolism, an increase in the ATP-ADP ratio, which leads to closure of this ATP-dependent potassium channel, which leads to depolarization of the cell membrane, opening of this calcium channel, calcium influx, and then exocytosis of the insulin from the secretory granules. A very nice mechanism that stimulates insulin secretion in the setting of glucose coming into the cell. When glucose stops coming into the cell, then insulin secretion stops. And it turns out that sulfonylureas and some other drugs also that we'll mention bind directly to this ATP-dependent potassium channel in an area that's been termed the sulfonylurea receptor. We don't really know what its natural ligand is, but it is a receptor that's part of the channel itself. And it stimulates the channel to remain open, which leads to depolarization and exocytosis of insulin. So based on this, can you imagine what the biggest problem with sulfonylureas is? Hypoglycemia, right? Because you bypass the normal regulatory mechanism for insulin secretion. So you can have insulin secretion in the setting of no need for it, right? Even if there's no glucose available, glucose levels are low, the insulin secretion will still go on because you've manipulated the receptor using this drug. And that really does turn out to be the main problem with sulfonylureas. So I showed you a picture like this before for metformin, and it showed you that metformin predominantly lowers fasting glucose levels, and that's really essentially true for sulfonylureas as well. Here you have before treatment, here's after treatment with glyburide, which is a common sulfonylurea, and you could see that there's a reduction in fasting glucose, but that in many cases the post-meal glucose excursion is really not that different. But you're starting out at a lower baseline, so overall glycemic control is improved. And you can also see over here evidence of sulfonylurea's mechanism of action, right? Here in the after glyburide in pink, you can see that insulin levels are higher, right? Consistent with its known mechanism of stimulating insulin secretion. So what are the problems? So the adverse effects of sulfonylureas, the primary one we just mentioned is hypoglycemia. And this is because we've interfered with the normal glucose regulation of insulin secretion. Now, it turns out that some people are more prone to hypoglycemia than others, and among them are older people. So older adults who are being treated with sulfonylureas seem to be most at risk for hypoglycemia, possibly because of renal impairment or decline in renal function that's very common with aging. The other thing to keep in mind is the potentiating effect of alcohol and some other drugs. And I think the combination of alcohol, which can suppress hepatic glucose production, and along with something like this that can stimulate insulin secretion, you could see that you stimulate insulin secretion, and at the same time you may be impairing the body's counter-regulatory response to a drop in glucose level. So this can be a difficult combination. The second thing about sulfonylureas is that they may cause weight gain, and that's actually something that we see with insulin itself and several other diabetes treatments. It may be the result of the higher insulin levels, or it may just be a result of improvement in glucose control itself. So in the uncontrolled diabetes state, there's glycosuria. There's actually wasting of calories into the urine. When you correct that problem, calories that previously were lost in glycosuria are now retained in the body, and there's weight gain. But we do see this not uncommonly with sulfonylureas. With some of the earlier sulfonylureas, there were some other problems. There was hyponatremia from an SIADH-like effect, but we don't see that with the ones that are in common use here in the United States. And very rarely there have been cases of hepatotoxicity or allergic reactions, but really I have to say these are quite rare. Okay. So summary, sulfonylureas are very inexpensive, which I think is a big plus for certain patients. They're all available as generics. They have a very long history of use, so we pretty much know what to expect. They're easy to take, one pill a day in most cases, and they don't tend to have a lot of nuisance side effects like GI upset or headaches or anything else. People don't usually have any nuisance effects when they take it, and it can be used as sole therapy or as combination therapy. I think it's very commonly used in combination with metformin. The downside is that not everyone responds to these drugs. About two-thirds of people, when you start them on sulfonylurea, will have a good response, and among those, about 10% per year seem to no longer respond to it, maybe because of this exhaustion of the beta cell phenomena. There's the hypoglycemia risk. Now, we don't have time to talk about this. It's a kind of a fascinating topic. But there's a lingering concern that there may be some cardiovascular risk or toxicity associated with sulfonylureas. It comes from a study that was done in the 1960s and 70s and has been disproven a number of times, and yet evidence keeps reemerging that there may be some cardiovascular toxicity, meaning increasing the risk of myocardial infarction. So just be aware of that. I think even now, if you look in the PDR and the official prescribing literature, it's actually there as a warning, although I think it's universally ignored by most physicians. Now, there are two other drugs that we'll mention that actually have a very similar mechanism of action as the sulfonylureas, but they're chemically distinct. They are not sulfonylureas. They've been kind of lumped together as a class called the glitinides. But the important thing to know here is both repaglinide and integlinide, they bind to the same sulfonylurea receptor on the beta cell and lead to the secretion of insulin by the exact same mechanism as the sulfonylureas. What's distinct about them is the kinetics of their binding to the receptor. And so they have a very quick onset and short duration of action. And so they're designed to be used at mealtime. Remember, we said sulfonylureas basically have very long duration of action. You give it once a day, and it does what it does essentially for a 24-hour period. That can be good, but that also can increase the risk of hypoglycemia, maybe between meals or if the person hasn't eaten in a long time. And so these drugs were developed to kind of get around that. There may be lower risk of hypoglycemia. You can dose them right with the meal. If the person skips a meal, then they skip the drug. And so in certain cases, they may be a little bit safer. Okay. So we're going to switch now to some of the newer drugs that have become available that are very interesting. And the next class are going to be drugs that are based on the incretin effect. So we've talked about, this is sort of a cartoon of an islet with the beta cells in green. And that our paradigm has been, right, that glucose is what stimulates insulin secretion. And obviously that's true. But there are other signals that also either promote or enhance insulin secretion, including signals from the central nervous system that we mentioned, but also, very importantly, the incretin hormones coming from the gut that work to enhance glucose-stimulated insulin secretion. And this phenomena of the incretin hormones that are produced endogenously to help to regulate glucose metabolism in the normal state have been leveraged to develop two new classes of drugs. So here's just a description or a picture of what the incretin effect is. And this is sort of a classic experiment where a normal individual is given the same amount of glucose either as an intravenous, sorry, this doesn't show up too well, either as an intravenous, which is in the triangles, or directly into the GI tract in the circles. And you can see that for the same amount of glucose delivered, that when you give it intravenously, that the plasma glucose levels are higher, leading to the suggestion that there's something that happens when you deliver the glucose enterally that prevents the glucose from going up. And it turns out that that's mediated through enhanced insulin secretion. So here, when the glucose was delivered directly into the intestine, that glucose levels, insulin levels go up much more briskly and are able to prevent this rise in glucose level. And this difference in insulin secretion or insulin levels when you compare enteral versus intravenous delivery of a nutrient is called the incretin effect. So a definition of an incretin is something that's released during nutrient absorption, right? Something that is released in the context of absorption of nutrients from the GI tract. And it augments insulin secretion at physiologic concentrations. This is a phenomena that occurs in normal physiology. And I think very importantly, when we start to think about incretin hormones or analogs as drugs, is that their ability to stimulate insulin secretion are glucose dependent. And so by and large, we don't have the problem with hypoglycemia with this class of drugs that we did with sulfonylureas, because in the setting of normal or low plasma glucose levels, they really don't do very much to stimulate insulin secretion. It's only in the setting of increased nutrient availability, higher or rising glucose levels, that they tend to stimulate insulin secretion. And the main incretin hormone, there are a number of them, but the one that has been leveraged as a drug is glucagon-like peptide 1, or GLP-1, which is normally secreted by the L cells in the intestine, mostly in the ileum and the proximal colon, in response to nutrient intake. So we said that GLP-1, as this incretin hormone, stimulates insulin secretion. And here you can see again our beta cell. And the thing to just keep in mind is that the receptor for GLP-1 is not the same as the receptor for sulfonylureas. And actually the mechanism by which incretins like GLP-1 stimulate insulin secretion is really different. It's a G-coupled G-protein coupled receptor that stimulates cyclic AMP and leads to insulin secretion by a different mechanism. Again, if you don't have beta cells, you're not going to have insulin secretion, but the mechanism itself is a little bit different than what we described with the sulfonylureas. The other thing that's important to keep in mind is that GLP-1 receptors are not just on beta cells, right? On beta cells, we can clearly see how they would promote insulin secretion. But incretin hormones seem to have a variety of effects, including effects on the alpha cells within the islets, so they decrease or inhibit glucagon secretion. There are also receptors on adipocytes in certain areas of the brain and within the stomach and the small intestine itself, all of which gives us clues as to some of the clinical effects that we see when we stimulate the GLP-1 receptors. So what are the action of the agonists for GLP-1 that have been developed for use? I'll mention just in passing that GLP-1 itself it could be very useful as a therapy, but it's degraded almost very quickly in the body. So when it's secreted, it does its work, and within minutes it's gone. So as a therapy, you'd have to give it by injection, sort of as a continuous infusion. It's not something that you could take episodically because it's metabolized and degraded very quickly. So analogs that are resistant to degradation of GLP-1 have been developed. So the GLP-1 agonists that we have enhance nutrient-stimulated insulin secretion. They suppress glucagon secretion, which results in lowering hepatic glucose production, which is good. There are receptors in the stomach, I mentioned, right? GLP-1 receptors in the stomach. And so we do see clinically a delay in gastric emptying, which may be a very important part of their efficacy. They're often associated with modest weight loss, probably even more than what we see with metformin. And so the delaying of gastric emptying may be responsible because people tend to feel full longer, or they have satiety, they're just not hungry, and they tend to lose weight. There's also evidence that maybe GLP-1 receptors in the brain could be involved, and that there may be a central anorectic effect that also leads to weight loss. And there's some evidence from animal models, and very little from humans, I have to say, that GLP-1 agonists may stimulate beta cell growth or mass, which is an attractive idea. Obviously, you know, if there's a decline in beta cell mass in people with type 2 diabetes, if you could somehow cause regeneration of beta cells, that would be good. And actually, it has been studied in the setting of type 1 diabetes, early onset type 1 diabetes, where there are beta cells available, still viable. There have been studies where they've tried to use GLP-1 agonists to stimulate the regrowth of beta cells. I don't think we have an answer yet about whether that's really an effective strategy, but it has been looked at. So I put this here. Does anyone know what that is? Gila monster, right? So the reason that it's there is because it's cute, but also because Exendin, which is the analog of GLP-1 that's been developed as a therapeutic agent, was first identified in the saliva of the Gila monster. And the two drugs that are currently approved in the U.S. for use are exenatide and liraglutide. They work, you know, really in the same way, agonists for the GLP-1 receptor. Liraglutide has the benefit of only requiring once-a-day dosing. Seems to be perhaps a little more potent than exenatide, but both of these are available for use. And here's just an example of what you would see. Again, this is fasting and then following a meal. Here's someone being treated with placebo. You could see plasma glucose levels go up. And here with exenatide, it's completely flat. There's no post-meal glucose elevation. This is a pretty dramatic result. I don't think that everybody who uses these drugs has that kind of result, but I show it here really just to highlight that in people who do respond, it can be tremendous. It can be really lead to almost normalization, especially of postprandial glucose levels, probably much better than any of the other therapies that we have. And they do it by stimulating insulin secretion. So remember, there's this sluggish insulin secretion, this delayed insulin secretion that's characteristic of type 2 diabetes. Well, in the setting of exenatide or liraglutide, there is an increase in a brisker insulin secretion in response to the meal. Now, I mentioned that native GLP-1 could be used. It's effective, obviously. It activates the GLP-1 receptor, but it's degraded very quickly. And that led some people to think, well, what if we could delay the degradation or the inactivation of endogenously produced GLP-1, and then this hormone would be around longer and would have more effect. And so this enzyme is called dipeptidyl peptidase 4, which is a ubiquitous enzyme. It's involved in many processes in the body. And it inactivates GLP-1 very, very quickly. And it turns out that it has been developed as a drug. Several drugs, actually. Sitagliptin, saxagliptin, linagliptin are three of the DPP-4 inhibitors that are currently on the market. And they work by delaying the degradation of endogenously produced GLP-1. Their advantage here over exenatide and liraglutide is that they can be given orally. They're given once a day. They tend to have relatively little in the way of nuisance side effects. So obviously, patients would tend to prefer these drugs over liraglutide and exenatide in some cases because those drugs need to be given by injection. So every story has its dark side, I guess. And I think we're just starting to learn a little bit about what the potential side effects of this class of drugs might be. I would say overall they're well tolerated. There haven't been a lot of problems with them. But they've been available maybe about 8 years or so, like 6 to 8 years. So we don't have decades worth of experience with any of these drugs. And the one issue that's come to light that seems to be has the most evidence for it is an increase in the risk of acute pancreatitis. And this applies to all of the GLP-1 based drugs, so the DPP-4 inhibitors as well as the GLP-1 agonists. And the increase in acute pancreatitis is really based on case reports. As I said, it affects all of the drugs. It's difficult to estimate the magnitude of the risk because there isn't a standard database for reporting of pancreatitis or other drug adverse effects once they've been approved by the FDA. But there's some estimate that about 0.1% per year of people treated per year might develop pancreatitis. It's also a little complicated because diabetes itself increases the risk of acute pancreatitis. And the true incidence in relationship to the drug is not completely clear. But there is a warning on the drug label, and many patients will read this and become concerned. There are a lot of advertisements on television by lawyers who say, did you take sitagliptin? You may have a lawsuit on your hands. So it's out there in the public media, and so people are concerned about it. The other thing has to do with C-cell hyperplasia or medullary thyroid cancer, which has been seen in rodent models with this class of drugs. Now, the rodent models in general are, not the same as humans, right? And most of these studies have been done in models that are prone to C-cell hyperplasia, where medullary thyroid cancer is common. If you've gotten this far in the endocrine course, hopefully you know by now that medullary thyroid cancer is quite rare. We do see it, but it's not the common form of thyroid cancer. There are some familial syndromes where we see it, but it's a distinctly uncommon condition in humans. So the relevance of this finding of C-cell hyperplasia and medullary cancer in the animal models, the relevance to people isn't clear. Certainly we wouldn't use it in someone who we know is predisposed to medullary thyroid cancer, but that's a pretty rare thing. And this also has a warning on the drug label. And when patients see cancer on a drug label, many of them become very concerned. There's some evidence that maybe liraglutide might be a bigger offender than exenatide here. There have been also some reports of acute renal toxicity with exenatide that may have been due to nausea, vomiting, and some dehydration, but that really hasn't been conclusively proven. And I'll just mention this here in passing because it has also become a hot topic, that it's been proposed that not only do these drugs increase the risk of acute pancreatitis, but maybe pancreatic cancer. This is based on very little evidence, but the knowledge that these GLP-1 or incretin hormones may have an effect on increasing hyperplasia or growth of cells in the ducts. And there have been some studies that have suggested that there is a risk, and other studies that have denied this. I just put this up here to show you in this summer's issue of one of the major diabetes journals. There was a point-counterpoint argument. Are these therapies safe? And this one says no, and this one says yes. And it's a very hot topic in the diabetes field right now. Hopefully we'll have some more information about this as time goes on. But it is a cause for concern, I think, especially among patients who are influenced by what they hear on television. Okay, so we're going to speed it up a little bit, I hope, and go through the next few drugs. So the next class that we're going to talk about are the thiazolidine diones. These are drugs that were first approved about maybe 15 years ago, and at the time were really considered very revolutionary because they were the first drugs where we could directly influence insulin sensitivity, so directly tackle insulin resistance, which is part of the main pathology in type 2 diabetes. And they work by binding to nuclear receptors, these PPAR gamma receptors, and they lead to activation of a whole variety of a gene. So it's not like one single thing that these class of drugs do, but they lead to the expression of many genes involved in lipid metabolism, involved in adipocyte differentiation, and also in insulin action. The example they're showing you here is TZDs binding to the PPAR gamma receptor, changing gene transcription, and increasing the availability of GLUT4, which is the glucose transporter that's responsible for bringing glucose into the cell in response to insulin. That's probably an oversimplification, because it turns out that what we probably originally thought about how these drugs worked is substantially more complicated, especially when you consider that the main effect that we see of TZDs is an enhancement of insulin-stimulated glucose uptake, predominantly in skeletal muscle, and yet there are very few of the TZD receptors in skeletal muscle. They're just not there. The receptors actually seem to be present in very high concentration in adipose tissue, and the concept has emerged that it's actually TZDs binding to PPAR gamma receptors in adipose tissue that lead to different signals, all right, either hormones or modulation of free fatty acid levels that ultimately have an effect on skeletal muscle glucose uptake. So one proposal is TZDs suppress lipolysis, so there's a reduction in free fatty acid availability. That would help to improve insulin sensitivity. And they also increase the secretion of this adipokine adiponectin, which has very important insulin sensitizing properties. So those have been two potential mechanisms by which the TZDs affect insulin sensitivity. So the metabolic effects we see with these drugs are improved insulin action, and actually a little bit different than some of the other drugs we've talked about. They tend to lower both fasting and postprandial glucose levels. They reduce free fatty acids. They tend to lower triglycerides and increase high-density lipoprotein. They may have favorable effects on LDL particle size, making them less atherogenic. And something that's very notable and probably part and parcel of their metabolic effect is they cause redistribution of fat away from the visceral compartment, where it's most associated with insulin resistance, the sort of metabolically active fat, and redistribute it to the subcutaneous compartment. So there are two currently available TZDs. An earlier drug called troglitazone was removed from the market because of serious hepatotoxicity. The current drugs have very little in the way of hepatotoxicity, so that's not a concern. But rosiglitazone has been shown to has been purported to have cardiovascular toxicity, so increasing the chances of a myocardial infarction. And so its use currently is highly restricted in the United States. In many countries, it's not even available, but it's restricted in the US. It's still sort of a controversial issue. Now, the adverse effects of TZDs are substantial, and I think that has sort of diminished enthusiasm, the original enthusiasm for this class of drugs. Number one is that they're associated with weight gain, and not just the weight gain that you'd expect from the correction of hyperglycemia and glycosuria and dehydration. In some people, it can be substantial, and not surprising when we think about the effect of TZDs can have on a variety of metabolic processes, including adipocyte differentiation. So there is definitely some increase in fat mass that comes independently of its effect on glycemia. There also is edema and fluid retention, and in some patients this can be pretty pronounced. In someone who already has an edema-forming state like congestive heart failure or nephrotic syndrome, the addition of a TZD could really complicate their management quite a bit, and it could worsen congestive heart failure in people who already have it. It doesn't have negative effects on the myocardium per se, but it can worsen the fluid status of someone with CHF. There's been some reports of dilutional anemia, not because of increased plasma volume, but not really significant, and hepatotoxicity has been rare. But the issues that have emerged more recently with this class of drugs is, as I mentioned, the cardiovascular issues with rosiglitazone, and then both of the TZDs have been associated with increase in fractures, in osteoporotic fractures, primarily in postmenopausal women, and also reports of an increased risk of bladder cancer. We'll kind of skip over this and just to highlight for you that although there was initial promise that TZDs would be cardioprotective for a variety of reasons, there was this report a few years ago that actually suggested that there was increased cardiovascular risk, and the use of rosiglitazone has been restricted for the last several years. So the next class that we're going to talk about are the alpha-glucosidase inhibitors. These are drugs that are not used that widely, at least in the US, but they're very popular in Europe. And they work by a completely different mechanism of action. So you know that in order for starches to be absorbed, in order for complex carbohydrates to be absorbed by the intestinal villi, they need to be broken down into simple sugars. And there's a variety of enzymes that are involved in this process. Someone had the brilliant idea that if you can block the degradation of complex carbohydrates down to simple sugars, that you could prevent their absorption. If you prevent their absorption, then you can reduce postprandial or post-meal hyperglycemia. And so the alpha-glucosidase inhibitors actually work on the glucosidase enzymes that are involved in breaking down starch. And therefore, unfortunately, they don't prevent absorption of carbohydrates. They just delay absorption of carbohydrates till more distal portions of the intestinal tract. So the two drugs that are available are acarbose and miglitol. And here's sort of a cartoon of how it's supposed to work. Normally, in the untreated state, carbohydrates are broken down by the intestinal glucosidase enzymes, and absorption of the sugars is in the proximal small intestine. If you delay the breakdown of these complex carbohydrates, then absorption of the sugars occurs later, more distally in the intestine. And remember that insulin secretion in response to a meal, in response to nutrients, is sluggish in type 2 diabetes. Well, if you slow down the delivery of nutrients, maybe that will be more in keeping with the sluggish insulin response. And they're showing here that there's sort of a blunting of the post-meal glucose level in this type 2 patient treated with acarbose. So its only action is to reduce the postprandial glucose excursion, right? It has very little or no effect on fasting glucose levels. And remember, that actually works on the food. It doesn't really work on the person, but it works on the food in the GI tract. So if there's no meal, there's no utility of the drug. It can be used as monotherapy or in combination with other drugs, and it's generally considered to be weight neutral, so it doesn't lead to weight loss, doesn't lead to weight gain, doesn't really have much effect on lipid levels. The main reason why it's not used very much is from the GI side effects, and you can kind of imagine that if you deliver complex carbohydrates to the colon, so they're not absorbed in the proximal intestine, but they're now available to colonic bacteria to metabolize, there's a lot of CO2 that's produced, and people have flatulence, diarrhea, nausea. Not very pleasant. So if you do use it, it has to be started very slowly, titrated up to the therapeutic range. That said, you know, as I mentioned, they're very popular in Europe. I have had very few patients who've ever been willing to put up with the side effects long enough to see if it really works. But it is available and can be used. One thing of note is that if hypoglycemia, now if you use this drug by itself, it doesn't cause hypoglycemia because it doesn't interfere with insulin secretion, doesn't enhance insulin secretion. However, if you use it along with a drug that could cause hypoglycemia and you want to treat the low blood sugar, you have to treat it with something that could still be absorbed in the setting of the inhibition of the alpha-glucosidase. So you wouldn't want to treat low blood sugar with a cracker, for example, because the starch wouldn't be absorbed, wouldn't be broken down and absorbed very quickly. So you have to treat it with glucose. The last class of drugs I'm going to mention is one that's hot off the press. Okay, it received initial FDA approval this year, and so there's a lot that we don't know yet about these drugs and how effective they're going to be in the long term. But I think again, understanding how they're dealing with the physiology is very illustrative. So the SGLT2 inhibitors, and the only one that's currently approved is canagliflozin. work by blocking the reabsorption of glucose in the renal tubule. So glucose is filtered in the glomerulus and then reabsorbed by this transporter in the proximal tubule. And this blocks that reabsorption so that the glucose actually goes out in the urine. So we're actually causing glycosuria, which is something that we typically have thought was a bad sign of poorly controlled diabetes. But here, with this drug, we're leveraging that effect to actually cause the removal of glucose from the body by inducing glycosuria. As you might expect, there's modest weight loss associated with this because you actually have a net loss of calories in the urine. There is a little bit of a tendency for an osmotic diuresis to happen, just as you would if you had a poorly controlled diabetic with glycosuria. And so blood pressures tend to be a little bit lower. And the main toxicity that's been described so far has been an increase in urinary tract infections and also genital yeast infections, vaginal yeast infections predominantly in women, but also men can have genital yeast infections as well because of all the glucose that's in the urine. It promotes the growth of bacteria in the case of a UTI or fungus in the epithelium in the skin. So this just shows you a comparison of canagliflozin with glimepiride, and it shows you that the reduction in hemoglobin A1c is about the same as what can be obtained with sulfonylurea, which is pretty good. Hemoglobin A1c reduction of about a little less than 1%. And the change in fasting glucose actually is a little more impressive here, reduction in fasting glucose by about 25 or 30 milligrams per deciliter. So pretty potent effect. And the other thing here is just to show you that the risk of hypoglycemia when this drug is used by itself is very, very low. Here's hypoglycemia with glimepiride, right, up about 40% in this case, and there are very few cases of hypoglycemia with treatment with SGLT2 inhibitors, which makes it sound like a promising drug. So these drugs can be used once a day. You have to modify the dose in the setting of renal insufficiency. Can be used as a single agent or in combination. Not to be used in the setting of severe liver disease or reduced renal function. The side effects we mentioned recently. There are some drug interactions that are important that you have to keep in mind. I think the main issue facing us at the moment is that the long-term safety of this totally new class of drugs is not known. So we're going to spend the last few minutes talking about insulin therapy, specifically in the setting of type 2 diabetes. And you know, the interesting thing is, people tend to think of insulin treatment means type 1. In fact, it used to be that we would call type 1 diabetes insulin-dependent diabetes, and type 2 would be non-insulin dependent diabetes. We got rid of those terms, and partly because about 50% or more of patients with type 2 diabetes ultimately need to be treated with insulin in order to achieve adequate metabolic control. So because type 2 diabetes is so much more common than type 1, the majority of patients that you see when you on the wards in the clinic, the majority of diabetic patients who are taking insulin will in fact be type 2. Not type 1 patients. So when do we use insulin in patients with type 2 diabetes? And so there's a number of scenarios where it's commonly used. Number one is people with really severe hyperglycemia at presentation. It's not uncommon for someone to have kind of weeks of polyuria, polydipsia, developing hyperglycemia, be admitted to the hospital, maybe with a hyperglycemic hyperosmolar coma or just very severe dehydration, very high glucose levels, and those people would always be treated with insulin, at least in the short term, until they can be adequately hydrated and managed with other agents. I think the most common scenario for insulin use in type 2 is people who don't respond to maximal doses of oral or other agents that we have available to us now. There are other acute situations where insulin may be used temporarily during some acute stress, infection, very common in hospitalized patients for them to be treated with insulin temporarily in the setting of stress. and surgery. Insulin is generally used in pregnancy, even for women with gestational diabetes, although that's starting to change a little bit. There's a little bit increasing use of oral treatments during pregnancy, but it's still very common for women with gestational diabetes to be treated temporarily with insulin. And in situations where there are contraindications to some of the oral meds, like for example, in renal failure, end-stage renal disease, you can't use metformin, can't use the DPP-4 inhibitors. There are many other drugs that are metabolized by the kidney, and you really can't use them, and so you may end up using insulin. So the next couple of slides, I think, are the really key points that I'd like you to take home about the use of insulin in treating patients with diabetes. And it's more the concepts that I think are going to be helpful to you rather than memorizing all the different forms of insulin and what their particular action profile is. And the first is about the approach. How are we using insulin? And here I'm going to contrast type 1 and type 2 diabetes again. So the goal in type 1 diabetes is to replicate normal physiologic insulin secretion. So remember, these people with type 1 generally are making none of their own insulin. And so we're trying to replicate the normal basal insulin secretion with increase at mealtime that is normal insulin secretion. And so patients with type 1 diabetes always need to have both a basal, a long-acting, low level of insulin availability, and then a prandial or a mealtime insulin that works quickly at the time of the intake of nutrients. And that most of the time, patients with type 1 are treated with multiple daily injections or a subcutaneous insulin infusion pump. On the other hand, type 2 diabetes, insulin is used in many cases to supplement endogenous insulin production. Remember, most patients with type 2 diabetes, especially in the early years of their disease, are making insulin. They're making actually fairly large amounts of insulin, but it's not adequate for them. It's not enough to overcome their insulin resistance. And in many cases, we can achieve our goals just by supplementing what they're already making, and for that reason, basal insulin alone may be adequate. And that basal insulin is often used in combination with oral meds or in combination with the GLP-1 agonist. It can be sort of you can mix and match a little bit to try to achieve the glucose control that you want. However, some patients with type 2 diabetes may ultimately require more physiologic replacement. Remember, when we talked about type 2 diabetes last week, I really tried to stress how heterogeneous it is, and it's true. There are some patients who just need a little touch of metformin and they're fine, and there are other patients who need a basal bolus insulin regimen, just like a type 1, and this changes over time for any individual too. So there are many different options for how insulin might be used in type 2, whereas in type 1, it's pretty clear that this physiologic replacement is what we have to aim for, which is really hard, by the way. It's very challenging. Okay. So there are a number of different insulin preparations that are available. They're all of the currently used insulins are human insulins. The earlier insulins, getting back to Banting and Best, they were isolated from animals. Pig insulin and cow insulin were very commonly used. Even I remember when I was a young person, these were the insulins that were commonly used. But now they're all human insulins produced through recombinant DNA technology. And we have a number of different options, and basically you can think about insulins in terms of how quickly they're absorbed from a subcutaneous injection. Right? All of the insulins that we have essentially are the same. They all bind to the insulin receptor in the same way. They all have the same biological activity. The only difference among the insulins is how quickly the body absorbs them following subcutaneous injection. And so we have rapid-acting insulins that are absorbed very quickly following injection that are listed here, and then the slower-acting or basal insulins that are injected, say, once a day and are absorbed very, very slowly over a prolonged period of time, providing that low level of basal insulin. The ones in blue are ones that are analogs, meaning that the molecule's been modified to change their absorption parameters. So here it is, yeah. So what determines these differences? It's the speed of absorption from subcutaneous injection. And I just reemphasize this because I think this is a source of a lot of confusion, not just among medical students, but among physicians as well, as what really is responsible for the differences of these drugs. So I'll tell you a way to think about this is, what would happen if you gave any of these drugs intravenously? Would you see any difference in how they work? And the answer is no, because the differences are all related to how quickly they're absorbed from subcutaneous injection. That's where patients put their insulin. They inject it under the skin. So if you give them intravenously, they're all identical, right? Because you bypassed the part of the process that's responsible for absorption in the usual outpatient setting. So it's the absorption from subcutaneous injection. Here's just some examples of how the insulin molecule has been modified to change its absorption. Here's a classic human insulin molecule with the A chain and the B chain. And you could see that by just changing one of the amino acids from the standard insulin molecule, you can increase its absorption. So there are two fast-acting analogs, insulin lispro and insulin aspart, that were developed just by changing a single amino acid. It changes the conformation of the insulin molecule and changes how it dimerizes and forms heteromers under the skin, which influences how quickly it's absorbed after injection. And so similar modifications have been made in single amino acids that actually enhance the formation of heteromers and slow the absorption of insulin. So conceptually, we're thinking about using insulin. It tends to think, looking at it in a picture like this. So one of the oldest insulins available is something called NPH. You don't see a whole lot of it anymore, although it can be very useful insulin. A typical insulin regimen in someone who has type 2 diabetes, who's just starting on insulin, might be to give them a single injection of this kind of insulin at bedtime. It starts to work in a few hours, it gradually peaks overnight and kind of wears off the next morning. This is a perfect way to control fasting hyperglycemia, right? To suppress the unrestrained hepatic glucose production that's very common in people with type 2 diabetes. So this is a very commonly used regimen. Sometimes you give it twice a day. So you give an injection in the morning, covers you for breakfast and lunch, kind of wears off, you give another shot. I think a more commonly used basal insulin these days is insulin glargine, which you inject it once a day, and it has a very flat action throughout the day to have basal effects at suppressing hepatic glucose production, but doesn't help necessarily with the postprandial needs. So that leads us to more complicated regimens. You know, some patients might be doing just fine on a simple basal insulin. There are other patients who are kind of moving a little more towards the physiologic insulin replacement type regimen. You can see in light blue here is the normal pattern of insulin secretion in someone who doesn't have diabetes. It goes up following a meal, it comes back down, doesn't ever go to zero, but it goes up very nicely and comes down in response to meals. And so we can try to mimic that by injecting different types of insulins in combination. This is a regimen where they're combining regular insulin, which is relatively quick, with NPH insulin. And this is a more ideal, more physiologic replacement, where there's a basal insulin here in red. That would be like glargine. That was giving you a low level of insulin availability all day long. And then following, at the time of each meal, there's an injection of a fast-acting insulin that leads to an increase in insulin levels that drop down very quickly after the meal. And this is and in blue you could see the normal insulin levels, and in the pink and red are what we try to do to mimic that by using injected insulins. And this is an insulin pump. And this is commonly used by type 1 patients that actually can deliver insulin through the little cannula that's inserted under the skin. And it delivers both a basal insulin all the time, a little bit, and then when you activate it, it will deliver a bolus or a rapid amount of insulin at mealtime. And Colette, who's our patient who'll be coming to speak to you tomorrow, she uses an insulin pump, and if you ask her, she'll show it to you. So the comparative effectiveness of diabetes therapies, we have a lot of options now. I mean, it's not really all that long ago that we just had insulin and sulfonylureas to treat patients. And it can be a little confusing sometimes to figure out which drug to choose, where to go. And I think it's important it helps anyway, to look at the effect in terms of comparing the drugs in terms of lowering the hemoglobin A1C or lowering the fasting glucose levels. And you can see there's a variety of effects. There are some drugs like sulfonylureas, metformin, and the TZDs that are really rather potent in terms of lowering A1C with effects on fasting glucoses. Some of the other drugs, like the alpha-glucosidase inhibitors, really have minimal effect on hemoglobin A1C and fasting glucose. So these are important parameters to consider. The other thing to consider, and it's not on this slide, is there are big differences in cost, too. And although many people have insurance and coverage for their drugs, the cost of something like canagliflozin, which just came on the market, is something like $400 a month, versus sulfonylureas, which are really about $5 a month. You have to kind of ask yourself, is it worth the financial cost when you're prescribing a drug for somebody? Now, it becomes important to understand the whole variety of diabetes drugs, because the truth is that most patients with type 2 diabetes end up needing to take more than one drug. And sometimes they need 2 or 3 or 2 or 3 drugs plus insulin. Type 2 diabetes tends to be a progressive disease where it becomes more difficult to manage over time. And this is just a study that was done a few years ago where they took people with relatively new onset type 2 diabetes, and they treated them either with a sulfonylurea, with metformin, or with a thiazolidinedione, or the TZD, and looked at how quickly they failed. How quickly did their blood sugar become out of control? And I think what they're showing you here is that the therapy of the failure of their initial therapy was quickest with the glyburide, intermediate with metformin, and most long-term maintenance of control was actually with rosiglitazone. But I think if you follow these patients out more than even 5 years, you'll see that the majority of people end up needing to have combinations of drugs. And so the question comes up, how do you figure out what combinations to give? And there are lots of ways to look at it. I think we don't have really strong evidence base to help us decide what combinations make most sense for any individual patient. But I think there's general agreement that the very first treatment, in addition to the diet and exercise components that we talked about before, is metformin. And then, depending on your goals and patient preferences, you can either add insulin because it's the most effective. It always works. There's no instances where insulin doesn't work. We can titrate the dose to whatever level we need, so it's really the most effective agent for controlling hyperglycemia. Sulfonylureas are the least expensive, so maybe that would be an option. Or if you really wanted to avoid hypoglycemia at all costs, say you had an elderly patient or someone with some cognitive impairment or someone where hypoglycemia was a real problem, like a truck driver, right? Someone who couldn't risk even a little bit of hypoglycemia, then you might choose one of these drugs that doesn't cause hypoglycemia. And I just show this to you, not for you to remember it at all, but just to show you all the different combinations that we can try. There isn't any one guideline that can tell us what combination to use, but there are many different considerations when you're selecting a drug treatment for type 2. So just to finish up, to review the drugs that we talked about today, drugs that reduce hepatic glucose production are metformin, the TZDs, the GLP-1 agonists, and the DPP-4 inhibitors, of course, and insulin also. Drugs that improve peripheral insulin action are TZDs, metformin, and metformin. Drugs that enhance insulin secretion are the sulfonylureas, the glynides, the GLP-1 agonists, and the DPP-4 inhibitors. Drugs that reduce glucose influx into the system are acarbose and miglatol, the alpha-glucosidase inhibitors, and the GLP-1 agonists, and finally, and metformin, and finally our newest drug, canagliflozin, which increases glucose excretion. So try to keep these things in mind as you think about the different drugs and how they interact with physiology. Okay, so we're going to take a 5-minute break and come back and talk about complications.